A very good afternoon to our listeners. As we all know, 24th of March is celebrated worldwide as World TB Day to spread awareness for this topmost infectious killer disease that is pulmonary tuberculosis. I would like to inform our viewers that this disease accounts for almost 4,000 deaths across the world per day. If we talk about Indian statistics, in year 2017, 27 lakh new cases of TB have been registered, out of which 14 lakh were of multiple drug variant resistant variant. Thus, this is a very deadly disease. Since the beginning of TB awareness program over the past few years by WHO, the progression of this disease has been controlled to a much extent. And for this year, the theme for World TB Day is "It's time for action, it's time to end TB." For our listeners, Sterling Hospital Baroda, which is the leading multi-specialty hospital of South Gujarat region, we have arranged a special live session with our leading chest physician, Dr. Sonia Dalal, who has been treating such diseases for more than a decade. Dr. Sonia Dalal is associated with Sterling Hospital since 15 years and has a vast experience in treating such deadly disease. I welcome you, ma'am. So today, she will help our listeners to understand this disease better. I would request our listener to come forward with queries which will be answered on this forum. So now, I would like to request Dr. Sonia to speak our viewers on this disease and the importance of World TB Day.
Good afternoon, everyone. I am Dr. Sonia Dalal, and I wish you all to celebrate the theme of this World TB Day. Let us end TB and let us conquer over it. So I have one question from Mr. Thakur. He says, why is 24th March celebrated as a World TB Day? Well, 1882, a scientist named Robert Koch, he discovered a bacteria which is Mycobacterium tuberculosis, which is basically the cause of this deadly disease called tuberculosis. And hence, in respect to Robert Koch, we are celebrating 24th March as a World TB Day.
Now, we have one more question. How does a person get TB?
Well, tuberculosis is an airborne disease. Airborne, what do I mean by telling airborne? That means any patient who is suffering from pulmonary tuberculosis coughs in a community or coughs anywhere, and the person who is near to him inhales, and if his immunity is down, will protract the infection which and then suffer from tuberculosis. So it is basically an airborne contagious disease.
One more question is coming from our listener. What are the symptoms of TB?
Tuberculosis can be pulmonary, that is the lung tuberculosis, where the patient would have cough, expectoration, that is he'll cough out sputum, fever, which probably would be evening rise, will have weight loss, will also complain of loss of appetite, will also sometimes also cough out blood in sputum. And when investigated, his sputum will show a AFP, which is positive for tuberculosis. Okay, so tuberculosis can be diagnosed first by an X-ray, where there will be a certain pattern which is shown on the X-ray. Very important thing everyone needs to know is that it is the only X-ray will not give a perfect diagnosis. You always need a microbiological diagnosis. So X-ray will tell about a pattern, whether there is a cavity, whether there is a pneumonia, whether there is an infiltration in which part of the lung, and then a patient is advised for a sputum test. And if the sputum shows acid-fast bacilli, which is pathognomic of tuberculosis, then the patient is suffering from tuberculosis. There are various other tests also to diagnose tuberculosis. We have a genetic test, which is a gene expert and line probe assay. We also get culture from the sputum, which is the gold standard for the diagnosis of tuberculosis.
Very valuable information.
Thank you.
So, ma'am, can it be is there any vaccine developed to treat this deadly disease, against this disease? Is there any vaccine?
I would like to tell the viewers very clearly there is no vaccine so far which has been diagnosed given for tuberculosis. And if anyone comes and says that there is a vaccine, it's basically a rumor that it's probably still in development or in the research, but till date there is no vaccine which is going to prevent a person from tuberculosis. That's a very good question. Number one, first thing is, how do we diagnose? As I rightly said, number one, X-ray. Number two, sputum with genetic test. Third, and culture. Once the patient with a genetic test shows that the patient has got primary tuberculosis, such patients are treated with 4-drug anti-tuberculosis management. Those are called the primary drugs. The primary drugs are isoniazid, rifampicin, ethambutol, and pyrazinamide. And then it is divided into an intensive phase and then 4 months of non-intensive phase. So in intensive phase, what we do is we give 4-drug AKT to the patient for first 2 months, and then later on for 6 to 9 months we give them 2 drugs or 3 drugs anti-tuberculosis management.
So how long treatment has to be
So as I said, to be very honest, doctor, we intensive and then the maintenance. So it is total duration is 6 to 9 months. Okay, intensive phase is first 2 months, and then the continuation phase is for 4 to 7 months. So total 6 to 9 months, depending on the type of the tuberculosis the patient is suffering from. But that is a primary TB. We are not talking about the resistant pattern. When you talk about resistant pattern, the duration changes. Yeah.
And one of our listeners is asking that after starting this treatment, she felt very well after 2 months time. So do she need to carry the treatment for the rest of the months?
That is a fantastic question the viewer has asked. When you start an anti-tuberculosis medication, the patient feels absolutely fine at the end of 1 or 2 months. But the treatment is long because you need to cure the patient. And for curing, you have to kill those bacilli. And when you have to kill the bacilli, it takes a duration of 6 to 9 months. And hence, even if the patient feels absolutely fine at the end of 1 month or 2 months, they have to stay in touch with their doctor and see to it that they finish the treatment. They don't have to stop on their own.
One more good question is there is a spread of tuberculosis?
No, not at all. There is no spread of tuberculosis by touching or eating together. It's, as I said earlier, tuberculosis is an airborne disease. So if a patient sneezing, patient coughs, and the person near to him inhales and has a low immunity, then only those patients would protect tuberculosis, not by touching or eating together or staying in the same house. Yeah.
What is the importance of weight? I think they must be asking about weight loss.
Weight loss is one of the symptoms for an infection or one of the symptoms for tuberculosis. And the other importance of weight is when a doctor prescribes an anti-tuberculosis medication to the patient, it is very, very important and pivotal in taking the weight of the patient and prescribing the anti-tuberculosis medications according to the weight. I would like to elaborate a little bit on this. Is if a patient is 60 kgs and if he is given the anti-tuberculosis medications of a 40 kg, then that patient would probably not be cured of tuberculosis, and he has all the chances to develop a resistance to that drug that he is taking because he is taking in a suboptimal dose.
Right. One of our listeners has asked, is tuberculosis curable?
Ladies and gentlemen, let us end TB, which is a very important theme of a World TB Day today. I will tell you that TB is the only disease now which is completely curable. It is, you have to understand a basic fact that if you don't play with your disease, if you take your medications well as prescribed by your doctor in the right dosage and at right time, then at the end of 6 to 9 months in a primary TB, or if the patient has drug resistant TB at the end of 2 to 3 years, it is completely curable. But if you try to play with your disease, if you take it in a suboptimal dose, if you skip the drugs, if you don't take it at proper time, then probably this disease can be absolutely deadly and take you to the ICU or show you the road to the heaven. Thank you very much.
One of our listeners is asking, patient is taking TB drugs. Why is there red urine and tears?
Okay, so this is very important. The patient is not passing blood in the urine. It is because of a drug called rifampicin, which causes the discoloration of the urine and discoloration of the tears, for which the patients need not panic. They should not be afraid of it. It is one of the acceptable, not a side effect, but reaction of rifampicin, which causes this discoloration of the secretions of the body.
Right. One of our listeners is asking, who are at most vulnerable to catch the tuberculosis? They are asking about the risk factors.
Okay, so any patient who has got pulmonary tuberculosis and he is infective, people staying with him, especially the pediatric age group, are most vulnerable. People staying with him who are immunocompromised, like diabetes, or a patient having CKD, that is renal dysfunction, undergoing dialysis, patient who has undergone a transplant surgery, patients who are on chemotherapy, patients who are having HIV, all those in close contacts are most vulnerable to develop tuberculosis. And any patient whose immunity goes down and inhales tubercle bacilli is also at a high risk of developing tuberculosis.
Ma'am, one more question. What is multiple drug resistance?
This is the problem which we have been facing for last 20-25 years. It's a deadly problem. The primary drug, which are the real drugs for tuberculosis, are isoniazid and rifampicin, which are called a bactericidal. What do I mean by saying what a bactericidal? Bactericidal means that these are the drugs which are really going to kill the bacteria. And when they are going to kill the bacteria, they are going to cause a complete cure. And if the patient develops resistance to these two important drugs, isoniazid and rifampicin, and they are not working on their tuberculosis, that means that that patient has got multiple drug resistant tuberculosis. Having said that, you need to have a correct diagnosis of a multiple drug resistance, and also need to get investigated that which are the drugs which are then sensitive, and give the treatment accordingly, subtracting isoniazid and rifampicin, and this treatment would last longer, which would last for 2 years or maybe 3 years.
So, ma'am, how this multiple drug resistant is diagnosed?
It is diagnosed by a genetic test. As I said, when we get a sputum for acid fast bacilli done, we also ask for a sputum gene expert or a line probe assay. When a gene expert is done, they would always say that it is positive for Mycobacterium tuberculosis, and then they give a resistant or a sensitive pattern for a very important drug called rifampicin. And rifampicin is, if it is sensitive, that the patient has got primary tuberculosis. But if they say that rifampicin is resistant, that means the patient has got rifampicin resistant tuberculosis. 90% of the time when rifampicin resistant comes, it is isoniazid which is also resistant. And then what we do is we get a sputum culture by an MGT method, which is what we call a sputum culture, simple culture done. And then after the culture comes positive for tuberculosis, we get the sensitivity pattern for the primary drug first, which is isoniazid, rifampicin, ethambutol, and streptomycin. We can now also add pyrazinamide. And if the patient has, the culture shows resistant to rifampicin as well as isoniazid, we diagnose them as multi-drug resistant tuberculosis.
So, ma'am, such a multiple drug resistance tuberculosis patient, what drug are we going to use?
Okay, I would like to take some time, Dr. Vikas, on this to elaborate. When I'm thinking of multi-drug resistant, that means my primary drugs, which are really bactericidal, are not acting in my patient. So that means the isoniazid and rifampicin is not acting. In that case, I would get a sensitivity pattern from the culture which has grown acid fast bacilli of my patient with second line drugs. What do I mean by second line drugs? Second line drugs are the aminoglycoside, which are the injectables, which includes kanamycin, amikacin, and capreomycin. Then we get a second line sensitivity for a fluoroquinolones, which is a levofloxacin or a moxifloxacin. And then we also have a sensitivity pattern for para-aminosalicylic acid, ethionamide, prothionamide, and linezolid, amoxicillin, clavulanic acid, macrolides, so on and so forth. And then we design the treatment regime for those MDR patients depending on how the sensitivity to the second line drugs come.
Now, one good question is, what is the role of gold quantiferol and TB, IgG, and IgM in our country?
Absolute rubbish in country like India, right? TB, IgG, IgM, gold quantiferon, IGRA, all those things are basically for the Western world where the TB is not so rampant. In a country like ours where the TB is absolutely rampant, this has no role. The gold standard is only sputum microscopy. So if a patient's gold quantiferon comes out to be positive, that does not mean the patient is suffering from a tuberculous disease, and we don't have to treat those patients.
Valuable information for the resident of India. Now, one more question is coming, ma'am. What is the latent tuberculosis infection?
Okay, so this is an answer that cannot be given in one line, but we all are living in a country where tuberculosis is very rampant. So we probably might be inhaling tubercle bacilli from the community. Now, inhalation of a tubercle bacilli and that staying in our body is a tuberculous infection when it is not manifested in form of a symptom. So it is called latent tuberculous infection. Any patient who has got symptoms like cough, fever, uh, hemoptysis, sputum, weight loss, then that infection gets converted into a tubercle disease. So all the tubercle infection need not be treated. It is only when the tubercle infection gets converted into a disease, then it is to be treated. So any patient who inhales tubercle has got Mantoux test, which turns out to be positive, does not mean that the patient has to be treated. That is called latent tubercle infection. TB is only to be treated when it is converted into a full-blown tubercle disease, not a tuberculous infection.
Valuable information.
Thank
One
you.
more question is coming, ma'am. If a person is vaccinated with BCG, can he consider himself to be protected against TB?
BCG is basically given to neonates and infants. So it is basically to protect very bad type of tuberculosis like neurogenic tuberculosis, and it has no protection in an adult patient. When they become adult, there is no protection to the BCG.
Right. One more question is coming. What is XDR tuberculosis?
So that is extensive drug resistant tuberculosis where the patient is resistant to the primary drug, that is isoniazid and rifampicin, and also resistant to one of the most important bactericidal, that is which kills the bacteria, aminoglycoside, second line drug, uh, amikacin, kanamycin or a capreomycin, and also resistant to one of the fluoroquinolones like a levofloxacin or a moxifloxacin. So then most of the bactericidal drugs which are used in tuberculosis are resistant. So that is called XDR tuberculosis. There is one more terminology which is now coming up in our country is TDR, which is total drug resistant tuberculosis, where none of the drugs of which are used for tuberculosis are working in the patient. They all are resistant. And that is really very pathetic condition where we have to now join hands and come together, diagnose tuberculosis early, preventing it from becoming MDR, rather than XDR or a TDR. If we prevent them from becoming MDR, I'm pretty sure that we can win over and end TB.
So in your practice, ma'am, are such cases coming to you with total drug resistance?
In my practice, we only see MDR, XDR, and TDR, right? So most of the times, what I see is XDR and TDR, and it becomes very difficult for us to, convince the patient to take the treatment for a long time, because God forbid if they have to take it for 2 years, 3 years. They have to get investigated every 2 months. Cultures have to be repeated again and again. We also have to convince the patient's relatives that and to spend on the drugs which are really very costly compared to the primary drugs. And we also have to monitor the side effects, because long-term medications of all the antituberculous drugs are coming up with side effects, like an aminoglycosides. Patient would probably have a renal problem. Patient would have a hearing loss. With ethionamide, prothionamide, there are liver dysfunctions. With cycloserine, there are psychological or psychiatric side effects. Where we have to we become like a family person of the patient, because they are with us for 3 years, and they have to spend a fortune on such drugs.
But still, we can consider
Yes, if there is an awareness that TB can be curable, if there is an awareness that they have to stick to their doctor and get all the investigations, whatever the doctor has written, and take care of all the side effects, yes, they have to take whatever the drugs has been prescribed by them in the right time, in right dosages.
you were speaking about side effect of tuberculosis. Few side effects, or one of our listeners has asked for side effects.
Yeah, so primary drugs, as I said, isoniazid, rifampicin, and pyrazinamide are the drugs which can cause liver dysfunction. It causes hepatotoxicity. So when we start the patient on an anti-tuberculous regimen, within first week or 10 days, we need to monitor the liver functions. And if the patient's liver functions are normal, we can continue. If the patient starts developing liver dysfunction, then we have to have an alternatives to stop those drugs which are hepatotoxic, add some other drug, and go on monitoring liver function, and go on adding once the liver starts becoming normal, one after the other. That is for the primary drugs. The aminoglycosides, that is kanamycin, streptomycin, amikacin, and capreomycin, which are good anti-tuberculous drugs, can cause uh, renal dysfunction, can cause hearing problems, can cause problem with balancing. So all those patients who come to us with hearing problem, all those patients who come to us with creatinine which is very high, we would probably monitor kidney functions. We would always ask them to whether they can hear properly or not, or we have to skip those drugs if they have any of this side effects. Linezolid, isoniazid, these are the drugs which are associated with neuropathy. That means they would probably have, a sensation, loss of sensation in the feet. They would probably say that, when I wear my footwears, it comes out of my feet and I'm not able to look at it. In such a case, we have some supplements which we give, but if it goes beyond control, we have to stop those drugs also. Levofloxacin, moxifloxacin has some cardiac side effects with the QT intervals, and they are also having some gastric problems. Cycloserine is a very good second-line anti-tuberculous medication. It has got psychiatric side effects, where the patient becomes very violent. Patient has some like a schizophrenic behavior, and they also have a suicidal tendencies. In such patients, we have to stop if they start developing such side effects. Again, I would like to add to this. I'm telling the side effects, but that is a role of a doctor to monitor those side effects. I don't want to scare my viewers nor to my patients. They don't have to be afraid, or they have to fear about the side effects. They all can be tackled, but fearing the side effects, please don't stop taking anti-tuberculous medications. If you observe any of this, please go and contact your doctor. Right? They can be tackled, and we all can win over tuberculosis together. So please don't stop those drugs on your own.
One of our listeners is asking, what is the role of diet?
A very valuable role, honestly. I mean, but you know, one of my patient had called me in the middle of the night and said, मैडम अगर मैं ये टीबी की ड्रग्स नहीं लूं और खाली अंडे खाऊं तो मेरा टीबी ठीक हो जाएगा क्या? तो दैट इज अ मिसनोमर. यू नो, यू नीड टू, ये ટીબી की दवाई तो आपको लेनी ही है. ટીબીની દવા વગર કોઈ વિકલ્પ નથી. હા, તમારી રોગ પ્રતિકારક શક્તિ વધારવા માટે તમે ઈંડા ખાઓ, હાઈ પ્રોટીન ડાયટ ખાઓ, કેલરીઝ વધારે લો, એ બધી વસ્તુ બરાબર છે. ઇટ હેઝ અ વેલ્યુ, but it is not the treatment. So a good diet, a balanced diet, a high protein diet with right anti-tuberculosis medication is the key to the success in winning over tuberculosis. તમે જે મને પ્રશ્ન પૂછ્યો છે ને ભાઈ, એનો જવાબ આપો કે તમને એક વખત મેલેરિયા થયો તો બીજી વખત થશે કે નહીં થાય? હા, એક વખત ડેન્ગ્યુ થયો તો બીજી વખત થશે કે નહીં થાય? રાઈટ? એક વખત એક્સિડન્ટ થયો તો તમે પછી એમાં ઇમ્યુન થઈ ગયા કે ફરી વખત તમે બરાબર જ ગાડી ચલાવશો ને એક્સિડન્ટ નહીં થાય? તો ટીબી પણ એવું છે. ટીબી એક પ્રકારનું ઇન્ફેક્શન છે. અને આપણે જે દેશમાં રહી રહ્યા છે, which is one of the most developing country, however we have a very high burden of tuberculosis. Once we have protected TB, that does not mean that we won't protect again. So you are also at the same risk of developing like any other person. That is most important and very close to my heart, which I would like to take some time. Patient નું કારણ, patient's cause, doctor ના કારણે, and these two things are very important. Number one, પેશન્ટ ને એવું કહેવામાં આવે કે તમારે આ ડ્રગ 6 થી 9 મહિના રેગ્યુલર લેવાની છે. However, once the patient starts feeling good, he is lost to follow up with the doctor. He thinks that I am cured and I will not take the medication. Here, patient is at fault. Now, let's go to the iatrogenic or doctor related. If a doctor diagnoses TB to the patient, right, doctor starts anti-tuberculous medications not according to the weight. So if a patient is 40 kgs and if the patient is given the drugs of a 60 kg, the patient will start developing side effects and patient would stop, or doctor would stop and say, you wait for some time, and patient is lost to follow. If a patient is 60 kgs and the drug is started according to the 40 kgs, then it is a suboptimal dose or a subtherapeutic dose, and the patient probably would not respond to that therapeutic regimen and will start developing resistance. Second thing is, if a doctor just starts anti-tuberculosis treatment on the basis of an X-ray or an ESR and does not get a sputum test done, a doctor does not get a sputum gene expert done, or a doctor does not get a sputum AFB culture done, and if the patient already has an initial resistance or a primary resistance and starts on a first line anti-tuberculosis medication and patient does not respond, would probably go on developing a resistance to that disease. Drug resistance can be prevented. Number one, taking the treatment as prescribed by the doctor, that is 6 to 9 months, taking the drugs in the right dosages, and also taking the drugs according to the body weight. As I said, body weight means if my patient is 40 kgs, I would give rifampicin 450 milligram, I would give isoniazid 300 milligram, I would give pyrazinamide 1000 milligram, and I would give ethambutol 800 milligram. And rifampicin and isoniazid always on an empty stomach. Some of the drugs are to be taken on an empty stomach for good bioavailability and good pharmacokinetics. Yes, of course they can be taken. If a patient who is suffering from tuberculosis and becomes pregnant, she can continue the drugs the way he or she are taking. She can continue the drugs the way she is taking, because the drugs would also pass on to the fetus, and the fetus would also be protected from developing tuberculosis. Yeah. Yes, so if the patient who's lactating is suffering from primary tuberculosis, and then the four drugs that she is taking is isoniazid, rifampicin, ethambutol, and pyrazinamide, she can continue taking it. Even if it passes in the milk, it goes to the breastfeeding child, has no side effect. Only thing if the patient is taking a fluoroquinolone, that is a levofloxacin or a moxifloxacin, then there is a red box warning, that's a black box warning, that that has to be stopped if she is breastfeeding, because quinolone should not be given to the child who's been breastfeeding.
Very good.
Yeah.
Are there any rapid tests to diagnose TB? One of our listeners is asking.
That's what I've been telling. There are good genetic tests now which are coming up, which is Gene Expert, which you would probably get in a day's time. When you give a sputum, or when you give any body fluid, you do a genetic test where you identify the TB, and then you also get the sensitivity pattern, which you get it in one day. As contrast to a culture which comes at the end of 21 days or 1 month, and then getting a sensitivity pattern which again takes one more month. By the time a patient has already taken 2 months therapy, he gets a culture report or a sensitivity report. But a genetic test, which is Gene Expert, or a line probe assay, which we call Heinz test, you get it in one day, and you get even the sensitivity pattern.
Right now. One of our listeners is asking, what is extrapulmonary tuberculosis and how it can be treated?
Extrapulmonary TB finds its way in all the organs of the body. The most vulnerable is lung, but then patient also develops the TB of the brain, that which is an extrapulmonary. Pleura means the covering of the lungs, where there is fluid collection, and that is called pleural effusion. Those pleural effusion are tuberculosis, which is tuberculous pleural effusion. The lymph nodes, the lymphatic system also gets affected by tuberculosis, which is called tuberculous lymphadenopathy. You have abdominal tuberculosis, you have renal tuberculosis, you have bone tuberculosis, where the presentation is like tuberculous osteomyelitis. You have joint tuberculosis, where there is a synovial fluid collection into the joint, which is called synovial tuberculous effusion. So tuberculosis occurs everywhere in all parts of the body, lung being most dominant.
Ma'am, what is the burden of tuberculosis in India?
It's very heavy. There are more, as you said, there are nearly 2.7 million cases of tuberculosis according to the WHO 2017 guidelines. And every year there are more and more multi-drug resistant being diagnosed, and now XDR tuberculosis being diagnosed. We recently, last year, there was a paper which turned out that now the TDR tuberculosis is also being diagnosed more and more. Nearly 4.7 lakh 47,000 new cases of MDR being diagnosed in our country. It's a huge burden. So my appeal to every one of us is that if you come across, or if you yourself have a cough which is for more than 2 to 4 weeks, if there is a weight loss, if you have a fever, please go to your doctor and please tell that I want myself to be investigated. Why is there a cough which is there for more than 4 weeks and it is not being controlled? So it is basically a conjoint effort, or a marriage between a doctor and the patient, and conjointly, we can probably win over first the diagnosis, real diagnosis, primary or a drug resistant, and treat it properly to have a complete cure of the disease.
One of our listeners is asking about the incubation period of tuberculosis.
So it's 2 to 10 weeks, basically. Normally, after inhalation, it would be probably around between 2 to 10 weeks. If the immunity is down, patient would probably develop a tuberculosis.
One of our listeners is asking, what is DOTS?
DOTS is a very nice program designed by the government, which is called Directly Observed Therapy Short Course, where the patient who goes is been diagnosed as tuberculosis, and according to the area where they are living, they are assigned a worker or a TB worker or a doctor, where in the intensive phase, every alternate day they are being called to give the therapy, or if they are in villages, there are Anganwadi workers or a TB worker who would go to their house every alternate day, and they will give the TB drugs. They will stand in front of them and they'll see to it that the patient suffering from tuberculosis will take the drug in front of them. That is in the intensive phase. In the continuation or the maintenance phase, every weekly the drugs are given when they are called to the uh, TB office, and then they are given the drug, and when they go back at the end of the week, they are supposed to carry the empty blister packs and give it to the concerned doctor or concerned Anganwadi worker, where they'll see to it that they have taken their drugs properly. And this is a very nice move to prevent the patients from developing drug resistance and not, preventing them from loss to follow.
One of our listeners is asking, how is pediatric tuberculosis can be diagnosed?
Pediatric tuberculosis is a huge problem. Number one, there are some of the patients who are already suffering from tuberculosis in the house, and if the pediatric patients are in touch with them, they need to be investigated by Mantoux test. If the patient is coughing continuously, they cannot bring out sputum. Sputum test or is basically for all those patients who are an adult, where we can tell them that you cough out the sputum, give it to us. So what we do is we normally take a gastric lavage in those patients. We pass a small dry tube, because whatever they cough out, they probably engulf that. So some of the tubercle bacilli are lying in the stomach. We put a small dry tube, take a lavage, send a genetic test, get an AFB stain done, and this is how we diagnose. Mantoux test, if it is strongly positive and the patient, parents or a grandparent are suffering from AFB positive, those patients are treated with tuberculosis. Gastric lavage turning out to be positive, those are treated as tuberculosis. If the gastric lavage turns out to be negative, Mantoux test is not confirmatory, then a pediatric bronchoscopy is done, where a pediatric bronchoscopist would pass in a small bronchoscope into the lung, take a bronchoalveolar lavage, and get AFB stain or an AFB culture, prove it, and start anti-tuberculosis medication.
Valuable information. With this, I would like to conclude our question answer session. If there is any case you want to discuss over this forum, any good case which you want to communicate to our listeners.
I would like to discuss one case which has probably been close to my heart every time. Uh, After 5 years of my practice, I got a girl who was in her mid 20s, and she was diagnosed as tuberculosis in Ahmedabad, and she was married just 1 year back. And when she was diagnosed with this tuberculosis, her husband left her, and she came to me completely dejected. She was completely depressed. uh, the financial condition of the family was not that good. There was only one person, her brother, who was earning in the family. And when she came to me, she was like, she had lost will to live. And she came to me, we diagnosed that she was suffering basically from an exterior tuberculosis, because when she was diagnosed as tuberculosis and was completely left out from in-laws and husband, she was taking her anti-tuberculosis medication very irregularly. She was sometimes skipping the drugs. And when she came to me, her culture turned out to be positive. Drug sensitivity report turned out to be that she had resistant to rifampicin isoniazid. She also had resistant to quinolones, and she was resistant to streptomycin as well. It took a long time for me to reassure her, bring life into her, talk to the relatives, talk to her parents, call her brother, or called her Bobby, and I helped her. Even the microbiologist who was doing helped her to an extent that we did all the tests at discounted rate. We talked to the pharma companies to give the drugs to her at discounted rate. And every time, from my hospital, we used to call her, look, you have to take this drug. This is the end of 2 months. Please come down to us. Let us get a sputum test done. If the sputum test is positive, we will continue your injectables and all the medications for a long time. If the sputum turns out to be negative consistently for 2 months, then we would probably get a sputum culture done again and sterile. If the culture turns out to be negative, after 6 months, we will stop your antibiotic injectables. This is how we continued. We continuously followed up with her. First, we brought life in her. First, we motivated her, and also the relatives. We helped her to our extent, but then the patient believed in herself, took the medications regularly. She also had a very bad side effects of the anti-tuberculosis medication. She had some hearing problem. She also had a liver dysfunction. She developed a very bad neuropathy because of linezolid. She went to a neurophysician. She also had some footwears which was designed by an orthotist, but she never stopped taking her anti-tuberculosis medication. And at the end of 3 years, we could cure this girl. She was back to life, and now she is married happily and she has 2 kids. So what I'm trying to tell is, if you believe in your doctor, if you think that TB is curable, and if the doctor has faith in, if the doctor has guts to treat you, I believe that we all can win over and conquer tuberculosis, and let us end together this deadly disease, which was diagnosed or discovered by Robert Koch in 1882. We are now in 2019. Our Prime Minister Modi ji has also said that by 2035 he wants to make India a TB-free India. So let us all join together and TB and conquer it. Thank you very much.
Very valuable information. It's been a very precious session today with you, ma'am, with lots of valuable take-home messages. I expect this session has enlightened the basic concepts of this deadly disease, and you have our listeners for early detection and complete care of this disease. Once again, I would like to thank Dr. Sonia on behalf of our listeners and on behalf of Salim Hospital for sparing her valuable time for us and for this noble cause. Thank you.
Thank you very much. Thank you.